So thank you so much for having me out here. I'm really excited to be here. And has anybody been out to Oregon before? A couple, yeah. She's been to Crater Lake, which is a gem for our community. It's really, really beautiful out there. So like Darren said, I'm the director of the Public Health Department. I've only been in that role since November, so just coming up on a year. So I'm still getting my feet under me. But I've been in Klamath for 6 years, loved every minute of it. And like Darren was saying, it's a rural community, so we have different resources, different issues and barriers that we deal with in a rural community. But it's a great challenge. And so I'm happy to be here to talk to other people who are exposed to rural health because it is very different. Does anybody know what this image is? Does it look familiar to anybody, these actors? Well, Elaine knows. Anybody? No? It's from Portlandia, which is a funny TV show. And I will say it's spot on. But I'm nowhere near Portland. That is a metro area on the opposite side of the state, on the rainy side. We're on the dry side. So Portland is up there. That's not us. Klamath Falls is down south central. We are about 20 miles from the California border. And typically we associate ourselves with the eastern side of the state because we are big counties with not very many people. So here's a picture of Klamath Falls, which is our central hub. It's the biggest city. That's Mount Shasta in the background there, and Lake Ewanna in the middle. We've got a cute little downtown, but that's about the biggest part of the community. Everything else just kind of spread out, but it's lovely. And so Klamath County is the size of Connecticut, but we're home to only about 66,000 people. So you can kind of get a gauge for how we are. And just to give you a little bit of demographics, we're primarily white, about 74-75% white, 12% Native American, about 12% Hispanic Latino, 4% Native American, 4% mixed race. So that's kind of what it looks like. We are poverty stricken. So you guys were all the coal mining area. We were in the logging industry, and that was booming. There was a lot of living wage jobs with low education requirements. Well, the logging industry went away, and so it left a lot of people in poverty, and now we have generational poverty, just like I understand that you all have here. And so Klamath is really trying to reinvent itself. What can we do better? Renewable energy is really big for us. We've got a lot of geothermal and a lot of solar. It's very sunny there. And so we're trying to do that. We're also looking at recreation and tourism. Those are ripe for the picking for our community. And so we're really working on that. Because of the geographic expanse in our community, transportation is a really big barrier, whether it's for work, for going to the clinic, whether it's for food. And in addition, being a rural community, we have a high HPSA score, which is a health professional shortage area. And so we don't have enough primary care providers in the community to serve the need, nor do we have enough specialists. So a lot of times people have to travel out of our county to receive certain care. So that kind of gives you an idea of what we're working with here. And so that paints this really bleary picture, and sure, we're a little rough around the edges, but we have a lot of really great initiatives that we're hoping in 10, 15 years, we're going to see a lot of our numbers get better and improve. And so Patty Case, she works for Oregon State Extension program, and she said Klamath County was struggling, but we thought we could create something better, and we are. We definitely are. We have rallied the community, both the people who have lived there forever and then people newer like myself, and it's really great to see a lot of sharing happening. Uh-oh. There we go. Okay. So as Darren mentioned, the county health rankings, those started coming out in 2011, and Klamath County was ranked at or near the bottom every single year. And unfortunately, we still are. But we used that as a call to action. We said, we can do better. This is embarrassing. And we're a great community. We want other people to think we're a great community. So what we call now the Core 4 came together, and so that was public health, where I work, the hospital system, Sky Lakes Medical Center, our federally qualified health center, Klamath Open Door, and Cascade Health Alliance, which is a coordinated care organization. We call it a CCO. It's basically local Medicaid. So Oregon is unique in how it delivers its Medicaid programs. So those 4 entities came together and formed the Healthy Klamath Coalition. And we decided that we needed to not do our own community health assessment and community health improvement plans. Why are we doing that? We need one, because we're all working, we have the same clients, right? And we're all living together. Why would we have different assessments? Why would we have different plans? And so we worked together, and in 2012, we published our first joint health assessment and health improvement plan. And we were fortunate in that 3 of those 4 entities, so public health has no money, we couldn't help contribute, but the other 3 entities pooled their money, and we were able to purchase the Healthy Klamath website. And this has been really great for us because it's a central location for information. It's a central location for event sharing, initiative sharing, report sharing, data sharing, all of that. And so it's been really great for us to rally around this one central point. We can put our egos aside and say, well, my organization's doing this. And so Healthy Klamath has been just this nice shining spot in the community. And we continue to grow. We've got a lot of cross-sector partners that are represented there. So we have schools and law enforcement and local officials, private citizens, human services, anybody's welcome. But those are kind of the people who come to the table. And we all have our own full-time jobs. We understand that, but we're trying to find where do we align so we can maximize our resources, maximize our time, and get things done. So here's just a quick snapshot of the Healthy Klamath website. And I just randomly picked one of our data indicators that it's all updated for us. And so we just try to keep it updated and drive people to that website whenever we can. So, like Darren mentioned, we felt that we were ready to apply for the Robert Wood Johnson Culture of Health Prize. We had heard about it, we'd seen other winners, and we thought, we're doing really great stuff too. I think we should raise our hand and ask to be put into the bucket. And so Darren already went through what the 6 prize criteria were, and again, we just thought we can do this. This is definitely us. So there was 190 applicants nationwide for phase 1. We made it to phase 2, and I think they whittled it down to 30 or 34 applicants. And then it whittled down to 10, and then they picked 4 winners, and we were really honored to be one of them. So here's a quick picture of our travel team. So we had representation from tribal health, our law enforcement, public health, the hospital system, and our local university, Oregon Tech. So so it was a 3-phase process. We had phase 1 application, phase 2 application, and a video, and then a site visit. And these are some of the initiatives that we talked about. And so I'm only going to highlight a few of these, but if we have some time at the end, I'm happy to talk more about any of these. And I'm so glad that there's, economic development in the hospital and different organizations in here, because we have the same thing and it's all related. So we paid a lot of attention on our food system because food insecurity is a huge problem, and yet we're an agricultural community. So where's all this food going? It's not going to our bellies. So we have done a lot of work on our food system. Klamath Promise is a graduation initiative. We had really poor high school graduation rates, and so a group got together and they started, I'm not sure if it's through the schools or if it's its own nonprofit, but anyway, they work on reducing chronic absenteeism and increasing high school graduation rates. And that's a really cool initiative that's been happening. Public safety has gotten involved. Obviously, feeling safe and actually being safe is a big part of health and wellness. And we got a new police chief, and he's just fantastic. And he's been really great about rallying the community and getting involved in health initiatives. Our built environment, so looking at our infrastructure. Oh, that's for her, okay. So making improvements to our built environment was really important to us. Again, you want to make a welcoming community. You want it to look pretty, you want it to be connected and have access to parks and safe housing and all that stuff. So that's been big for us. Tobacco policy, and we've had, fortunately in the past couple of years, a lot of success in passing tobacco prevention policy. Health equity, obviously that spans across all of these things, but there were certain initiatives that we did with our tribes that were pretty cool in terms of health equity. Klamath Works is a job training / life skills program, as well as a centrally located health and human services campus. And that is still under construction, but we're working that way. We have a rural health campus, which is Oregon Health and Science University, OHSU. They have satellite hubs where people try to go and become trained in rural medicine or rural health care. And Klamath Falls became one of those hubs. And then just data sharing. And again, we do that through the Healthy Klamath website. So like I said, I'm just going to highlight a few of our initiatives. So the first one is the food systems. And it's kind of been this perfect alignment of who's in the community and who's been doing what, and it just happened to align. So one of the really great things that's been happening is the produce connection. The food bank teamed up with several community partners, obviously the traditional partners of, well, there's the food pantries and the schools and things like that, but then we also partnered with the parks programs, and they did free summer lunch program, and we thought, okay, great, people are out here already, let's bring fresh produce instead of just the peanut butter and jelly sandwiches. So that started back in 2014. They moved 65,000 pounds of fresh fruits and vegetables throughout the community at 2 sites. Then by 2016, the program had increased almost tenfold, and they distributed 600,000 pounds of fresh produce throughout the community. They did that at 14 main sites and 4 sub-sites. So those sub-sites would be the park programs, the summer lunch programs, and then the other sites were just, for example, they would have one at the Mission, but it was open to the community. No questions asked. You don't have to show a pay stub or anything. I could go get fresh produce if I wanted. And so they had it all over town, different days, different times, that kind of thing. So fast forward to 2018, they reached their goal of distributing over 1 million pounds of fresh fruits and vegetables. And that was such a great initiative because the food bank had to take the lead. They have the access to the produce. But then they made relationships with all of these sub-sites and these sub-programs. So now they had a produce connection site at the clinic, at 2 of the clinics, in fact. They did it at the Mission, like I said. They did it at the park. They have one at WIC, where WIC is for us in the health department. And so that's been really great. And then they've also, in the past couple of years, have been trying to not only increase access to those fruits and vegetables, but then teach people how to cook with them, because that's the second part of the issue, right? And everybody in Klamath has a barbecue grill, or if you're homeless, you've got a fire, right? And so they wrote some grants and they got those little grill pan thingies, and they did grilling demonstrations out at the park and at these sites so that people could then just grill up their fruits and their vegetables. And it made it fun, it made it tasty, and hopefully avoided food waste. We haven't been tracking that. The other nice thing about Produce Connection is it then stretches people's SNAP or their WIC dollars, because now they're spending less money on the fruits and vegetables that they couldn't afford before. Now they can either visit the food pantry less because they have more food that they've already got, or they can stretch those dollars further. So that's been a big success for us. And since, 2011, we did a food needs assessment, and then we just redid one in 2018, and we did see our food insecurity rate go down. And so that's really great. We're hoping to see it continue to go down because childhood hunger is still an issue, but we're working on it. So Produce Connection, that was a really great one. Klamath Farmers Online Marketplace, or KFAM as we lovingly call it, is a really cool initiative that, as far as we know, it's the only of its kind in the nation. And what it is, it's It's an online farmers market. So we have local producers who are either farmers or ranchers or beekeepers, or they raise chickens, and have eggs and stuff. And every week they post what they have available online. And then customers like myself can go online and say, okay, I want a dozen eggs, I want a jar of honey, and I want the beets and the tomatoes. And then I go to pickup day and I pay my money, and now I've got fresh local produce. And the other nice thing is they accept SNAP dollars, which is the food stamp program. And so once again, we're finding ways of, we've got all this local produce, let's keep it in the community and let's get it to those who need it the most. Right now, what we're working on is reducing the transportation barrier to get the Klamath Falls, Klamath Farmers Online Marketplace produce, because it's at the drop-off location, or the pickup location more so, is at not the most convenient place, but we needed a big area. So we're working with our non-emergent medical transportation folks to make that a site so people can use that benefit. So we're working on that, but regardless, the program's been really successful for us, and they're trying to grow it so that they can, now hopefully we can accept credit cards because it's been cash only. And so anyway, we're working out some of the kinks, but KFAM has 509 registered users and 12 SNAP users. So really the indicator that we're looking to do is how can we increase the SNAP users. WIC is a little bit harder because just some of the other state regulations, and so we're working to hopefully be able to accept WIC one of these days, but we're not there yet. And then Find Your Farmer event, we have a local farmer, and she has a passion for community health. And she said, once again, we've got all these great crops growing right in our backyards, and yet all of this produce is moving outward. So she invented the Find Your Farmer event. And so what she did is she invited all the farmers in the community and farmers, producers, ranchers, and said, look at all these great things that you guys are producing. And she said, okay, I'm going to get the restaurants and grocery stores to also come to this event so that they can cross-pollinate and they can decide, well, I want to buy your beef for my school, or I want to buy your lettuce for my restaurant. And so they've had 3 events now this year, and now the schools are buying local produce, the restaurants are buying local produce, and the grocery stores are buying local produce. So that's been a really, really fun and exciting endeavor for us, because again, we're trying to say we've got great healthy food here, and when you're shipping it not very far, the costs are lower. So those are some of the initiatives that we've had in our food systems work. The final piece to this puzzle is, it was kind of a unique situation where we had a Safeway in our downtown area, which most of the neighborhoods right in our downtown are pretty impoverished. And something happened with the Safeway on the big corporate level, and they closed. So now we had a food desert, and the pharmacy closed. And so a lot of these people who have very limited transportation or mobility, now all they had was a corner store market instead of a full grocery store. And so it was empty, I think, for about 2 years. And we kept trying to find a grocer to come in and help, and economic development was there helping, and we just couldn't get anybody to bite because it was a kind of a small location. And anyway, so our local county commissioners decided we're going to buy that building, and we are going to find our own grocer, and we're going to find somebody to come and run the pharmacy. And so sure enough, the local government did something a little non-traditional, and they bought that building. And within about a year, they found someone to come in and run that market, and then they partnered with Sky Lakes Medical Center, our hospital system, to come in and run the pharmacy. So it took a lot of collaboration, but they then fixed the problem of having a food desert in our downtown area. And so now that's been really great. So we're trying to really support those kind of efforts with our local officials. Any questions on food system stuff? Okay. So next we've got the built environment. And this has taken several forms, but we all know that our zip code can oftentimes be more impactful than our genetic code, right? Where you live matters. And what we did, so Dr. John Ritter is a GIS, a Geographic Information Systems professor at Oregon Tech, which is our local college. And he partnered with our hospital system. They gave him over 60,000 de-identified records and said, we want you to map these health conditions from our community. And so he mapped out diabetes, high blood pressure, high cholesterol, obesity. I think it was those four, and then he overlaid it with walkability. And all of these maps are on Healthy Klamath, by the way, so I highly encourage that you go look at them. But what we were trying to do is we said, well, we really want some infrastructure change. We want a protected bike lane in our community, but we don't know where to put it. So we used these maps that showed, well, where are the health issues so we can know where to put this bike lane. And what we found is there was 2 neighborhoods that were kind of hot spots for bad health. And they're go figure, the poorest neighborhoods in town. But they found that one neighborhood was older in age, and they already had a lot of chronic conditions, versus this other neighborhood that had high obesity, not as many chronic conditions yet, and it was younger. So we thought, well, that might have more impact because you're more on the prevention side. And so we decided to build this protected bike lane right in this corridor through this neighborhood. And so now we've just come up on, this summer was the 1-year mark of that bike lane being opened. And what we're trying to do now is connect that bike lane all the way to our beautiful park on the other side of town. So we're trying to connect downtown with the park in between these neighborhoods. So what we're hoping to see is property values going up, less crime, people, more people out on the street utilizing it, and we're also hoping to see increased physical activity, lower diabetes, lower hypertension, all these things. It all goes together, but we're hoping to see that in the next several years. So that was really cool. The other thing is a report came out from the state and said Mills neighborhood, which is the poorest neighborhood in the community, is one of the top 5 hot spots for poverty and poor health in the whole state. And, we don't really like having that label. And so they formed a neighborhood association, and they said, well, first things first, let's just clean up the neighborhood. Let's make it look and feel a little bit nicer. So our police chief said, I'm in on that. What do you guys need from public safety? And so they said, well, we want more patrols because seeing more officers around deters the bad guys and it makes people feel a little bit safer. They also worked with city code enforcement, and they said, okay, well, we've got all these boarded up houses, there's junky cars, there's refrigerators on the sidewalk. I mean, people just put their stuff out. And they said, we want that gone. And so they did a huge neighborhood cleanup. The county commissioner said you can dump for 1 day for free. And law enforcement helped with that cleanup. City parks helped with that cleanup. The neighborhood association helped with that cleanup. Code enforcement was then saying, you need to unboard these windows and you need to fix them. And so all of this kind of came together. And then seeing that, the local CCO, the Medicaid provider, said, you know what, we're going to renovate your park because it's old and it's junky and, people are using it as their needle exchange area. There's needles everywhere. We need to make this better. So they invested, I think, $60,000 or something. They closed their office and they went and they redid the park in just a couple of days. And now a new business said, we see the potential in Mills neighborhood. I'm going to open my restaurant right in the middle of it, right next to that park. And so what we're seeing in just 2 years is a lot of revitalization of people are buying the houses there now. They're using the park now. They're going to that little restaurant. And it's been really great. And now that sentiment is really expanding. So we've had another restaurant who's come on the outskirts of that neighborhood, and they've plopped themselves in there. And the mayor said, well, let's put like pretty twinkle lights up for the winter and make it just look a little bit nicer. So those kind of built environment changes are really, really important because perception has a lot to do with your well-being too. If you think that park is unsafe and junky, of course you're not going to use it. Nobody blames you for that. And so we've actually now seen 4 new or renovated parks happen. And they've been paid for by the hospital system and the CCL, which is really, really unique. And we're really grateful for it. We also have started doing a lot more intentional planning around our infrastructure. So we were able to get a grant and had this really great cross-jurisdictional group, and we created an urban trails master plan. And so we hired a professional engineering firm, and they came in, and then the advisory committee said, okay, well, here's all the trails, and here's where we need trails, here's where we need improved sidewalks, here's where we need just improved like shoulders, whatever that may be. And so now we have this really beautiful master plan that has cost estimates, what the treatment would be, where it's located, what the priority is in terms of what the community said. And just maybe a month ago, there was a grant opportunity that came out for infrastructure, and we said, great, we've got this urban trails master plan. Let's look and see which thing that we can implement. Because the one thing we didn't want was a plan to collect dust on the shelf, right? We wanted it to be usable, and we are using it, which is really exciting. We also created a Safe Routes to Schools master plan, and we were able to do that through grant funding, because Safe Routes to Schools, I'm sure you have it out here, and that's a really big program. And so once again, now we have this plan done, and when monies become available, we know exactly where we want to put them. We don't have to go through the whole process, it's done. And we've also found that having those plans in place makes you just more competitive for the grant funding in general. And so that's been really, really helpful for us. Any questions on that? Yeah.
That neighborhood, that was sort of run down, and you had the renovation. Were most of the houses owned by the people who lived there, or did you have an issue with landlords who owned multiple houses that didn't fix them up?
Both, because a lot of it's very old housing, I think built in the 20s, and either it was landlord run and kind of slumlordy, or it was older adults on fixed incomes, and they either couldn't afford or just physically couldn't fix up their houses anymore. And so the code enforcement piece was really big for the landlords. And then the city issued mini grants for the other houses. So they said, a coat of paint would make this way better. So they did these little grants from the city to help spruce things up a little bit. So yeah, a little bit of both. Any other questions? Yeah.
Your urban trails improvement plan.
Yeah.
Was it embraced by the municipality, by the city?
Yeah, it was. And actually I don't know what his title is, like the assistant city manager was the one really spearheading the project. And so obviously you have to have the passionate people about it, and he was. And so it was really, I don't recall there being county elected officials involved, but there were city elected officials, public health, the hospital system, the Trails Alliance, parents, all kinds of people were really involved in that. And actually it lives on the city website. So yeah, good question. Okay. Any other questions? Okay. As I mentioned, tobacco prevention policy. Obviously, I've got a passion for this. My very first job out of my graduate program was the tobacco prevention education coordinator. And so there's a lot of tobacco use in eastern and southern rural Oregon. A lot of it is chew, but a lot of it is cigarettes as well. And primarily we were working on tobacco-free city properties, tobacco-free county properties, tobacco-free parks. We got the tobacco-free fair. So we had enough traction going on that, but we wanted to do better. And primarily we wanted to protect kids from tobacco. So once again, we partnered with Dr. Ritter in that GIS department, and we said, we want to know where the tobacco retailers are in relation to the schools. And so he created this map, which again is on the Healthy Klamath website. And so he did these buffer zones. And so I think it was a 1/4 mile buffer zone and then maybe 1/2 mile. I can't remember, it's on there. But anyway, so what we saw was, gosh, there's a lot of tobacco retailers right next to the schools. And we also conducted a tobacco retail assessment. And so what we were looking at is, are there advertisements all over the windows and outside? So when these kids are walking by it to school, are they seeing that? We also looked at, where are those signs and ads placed? Are they at adult eye level or are they at kid eye level? And guess what? There was a lot at kids eye level. And you know where else the tobacco products were placed? Right next to the candy. And so, it's researched. The tobacco industry knows what they're doing. And we said, well, we know what they're doing too. We want to fight against this. So we were very fortunate that we got new county commissioners who were, they were happy to buy onto this concept of tobacco retail licensing. And we had also approached the city, and they said, well, the city always does everything first. If the county will do it, then we'll do it. So we said, okay, let's get the county. And so they passed, because we said, you have to have a license to own a dog, you have to have a license to buy a Christmas tree, but you don't have to have a license to sell tobacco. And they said, you're right. So they passed. And then the city passed. And so now tobacco retailers, they have to get licensed, and they have to post quit line information right at the register, and they actually have to be checking IDs, because the other thing that we found was 1 in 3 youth were able to successfully purchase tobacco. Not okay. And so now we're doing a lot more enforcement and education with our retailers, saying, I saw you look at the date on the card and you still sold. What can we do to fix that? So we're working on that right now. We unfortunately haven't seen a huge reduction in our underage tobacco sales numbers, but we're working on it. In addition, that same little restaurant market that opened in the Mills neighborhood, they were selling tobacco. And then we just went back to them saying, would you be willing to not sell tobacco? Because we're really trying to make this a healthier place. And they said, you know what? That license fee is not worth the money I make from tobacco. And yeah, we do want to make this healthier. So they're giving up their license. They're not going to sell tobacco. Now, obviously, that's one little win, but that's one step closer to where we want to be, right? In addition, we are working on more tobacco-free places. Just in the past couple months, I went to our county commissioners and they said, no, we're not ready to do tobacco-free county properties as a blanket statement because of the courthouse and county corrections, and just there was a few issues. And I said, that's fine. But they said any other departments that want to go tobacco-free, they are empowered to do so. And so our developmental disabilities and our veteran services have said, yeah, we want to go tobacco-free. And they're right next to public health, and we've had a tobacco-free policy for years. And so we're slowly building out the tobacco-free campus property, so that's pretty exciting. We also tried to get tobacco-free downtown events, and that was a no-starter. People were up in arms. The Downtown Association was really supportive because they said, well, we have all these events, we're trying to make them family-friendly, and when people are, smoking all over the place, and there was tons of litter downtown. But the business owners, a lot of them said, no, we're not doing this. This is against our rights, all this stuff. So we said, okay, what about just tobacco-free events downtown? And they said, we can do that. So right now we're working on changing some of the policy to just make it, when we have our third Thursday event and the farmers market event, they're going to be tobacco-free. And that has been perfectly fine. And so those are some of the changes. We've had setbacks, sure. I just told you about them. But we're taking the ones where we can get them and hoping that people see it's not this big scary thing, and we're helping people who are trying to quit stay quit because now they're not being exposed. So we're just trying to build that culture. So those have been really exciting. It says wellness zone on here. What we're trying to work on now is our hospital they've had a tobacco-free policy for, 5 years now. And right next door is the college. They have a tobacco-free campus. And then we've got all these other little clinics in between. But what happens is then all of the smokers are just going to the edge of the property and smoking, and all the litter's going there. And so, I mean, we don't want to just say you're not welcome here, but it's getting around the policy. And so what we're trying to do now is create like a wellness zone. And we've gone beyond just tobacco prevention. So we want to create all the spaces will be tobacco-free, but in addition, we want to put up signage of here's great walking paths, by the way, and we're actually looking at getting a bike share because it's a decently sized campus. And so we're trying to encourage just wellness in general. Go out and enjoy the beautiful scenery. Go out and have a walk on your break. And by the way, it'll be tobacco-free while you're doing it. So that's on the horizon. It's a big fish to fry. So we're working on it, but that's where some of our plans. Yeah.
Have you guys had any conversation or position you might take on vaping?
We are very against it. And a lot of times when the policies are written, vaping is included in those. And I'm glad you brought that up because we just talked with the school principals for our county school district, and they said what was it? I think it was 50% of kids had been caught either vaping or with vaping products. I mean, talk about your next generation of an addict. That's really scary. And now we're finally seeing, that sounds bad, but we're finally seeing some really negative health consequences of vaping.
40%
So
in West Virginia.
yeah, it's really high.
Plus the parents that are buying it for the kids.
Right. The other thing too is marijuana is legal in Oregon, both recreationally and medicinally. And so you're seeing people vaping marijuana products. You can't differentiate. You don't know what's coming out of that vapor. And a lot of kids are getting a hold of that. So we're trying to get in front of the marijuana stuff, but unfortunately, public health is not funded to do that work. We're trying to get some of the tax dollars from marijuana money, but that's already been appropriated other places, and so we're trying to fight for it. But yeah, good questions. Okay, so moving on. We have a community health worker program. It's called Outpatient Care Management. It's run through the hospital, but is funded by our CCO, so through Medicaid dollars, and then it's supplemented by the hospital system. And it started out as a transportation program. So it was just non-emergent medical transportation, NEMT. And we hired 3 community health workers, and we were only serving Medicaid clients at that time. But very quickly, we realized people can use a lot more than just transportation, and we can have a lot bigger impact than just that. So what we still have the transportation benefit, and community health workers will still go to your house, they'll pick you up, they will take you to your doctor's appointment or your dentist appointment or your mental health appointment, and then they'll take you to the pharmacy, and by the way, we'll take you to the grocery store on the way home. And we tried to do this big wraparound service. We expanded from just having community health workers to then having a nurse, to then having a social worker, and now we have CNAs. And so it's this really nice program where we have a little bit more of specialties, if you will. And so there's a community health worker and a nurse assigned to people who have just been discharged from the hospital to make sure they're going to those follow-up appointments, they know what to do with those discharge papers and what that all means, and they have their medications, they know how to use them, make sure they're set up for success. And then we also have teams that work with people who have chronic conditions who have just been poorly managing them for a long time, and they want to get healthier. And so, for example, we have a gal who was always in and out of the hospital. She has a lot of chronic conditions. She's obese, doesn't have a car, and they worked with her, and not only did they take her to her doctor's appointments, they would go to her home, make sure she had everything, but she said, I really want to go to the YMCA and take some classes, but I'm too scared to do so myself. So that community health worker took the class with her, and now she's off and she does it by herself. So we do those kinds of things to really meet people where they're at. We're being sensitive to their situation, to their needs, and by the way, it's a free program. So that's what's really exciting about it. The one unfortunate piece is the non-emergent medical transportation benefit is only available to people on Medicaid. So if you have Medicare, those community health workers and nurses and social workers can still help you, but they can't provide the transportation. So that's a sticking point that we're trying to work through right now to try to figure out, well, gosh, these people are on fixed incomes, maybe they've lost their licenses, they need transportation. So we're working on that. We're working with the senior center. But overall, this has been a wildly successful program. And before I left this program, I did some program evaluation. And here's just a few quick stats. So, and this is just for fiscal year 2017-2018, okay? So we had 692 people actively engaged in the program. So, and that wasn't all at once. They, came on, came off as needed. We provided almost 10,000 home visits, office visits, and phone calls, so at least a touch with these people. We provided over 1,800 rides to people, and we travel, like I said, our county is the size of Connecticut, so we would drive an hour and a half this way to go pick somebody up and take them an hour and a half this way to go to their doctor's appointment and back. What we saw was a 35% reduction in emergency department visits and a 49% reduction in hospital admissions. And this continued 1 year after graduating the program. That not only is nice for the patient, because nobody wants to be in the hospital, nobody wants to go to the emergency room, right? But in addition, those saved dollars that now the hospital and the CCO had back were then used to invest in our built environment. So the money that was saved on some of these programs that money was used to renovate the park. The hospital did one park, the CCO did another park. So that's how this all comes together, right? We're working together, we're saving the resources, and now we're reinvesting in our community to make it better and healthier. It's been wildly well received as well, because we weren't sure if people wanted us to come into their homes. The other nice thing is we have Spanish speakers on staff, and so we are able to engage the Hispanic population. We've got a lot of migrant workers who come in and out. They don't want to go to the hospital because maybe they don't have papers, and so we've been able to engage that community as well. Another piece of this is the Oregon Health Science University rural campus. So what this is, OHSU is located up in Portland, way far away from us in the urban area. But there's this incredible need for providers, clinical providers of all different variety that should be working in rural communities. And so they've created this rural hub in Klamath Falls. And how it works is there's all these different disciplines. So we've got medical residents, PAs, nurse practitioners, pharmacy students, dental students. We're working on getting public health students, but what they do is they come and they do rotations within our community. And they, as part of that rotation in each clinic, they also have to participate in a community health improvement project. And the way those projects get selected is they're actually soliciting project ideas right now. Is somebody like myself would say, well, I've got this infant mortality group and we need X, Y, and Z done. Would you consider having your students help on this project? And so the past couple of years, we worked on a pregnant smokers initiative with the rural campus. We've worked on a chronic disease self-management program with these resident, or with the students. And they rotate at different frequencies. So I think the pharmacy students come for 8 weeks, and the PAs come for 4, and the dentist ones come for 12. So it's kind of hard to juggle sometimes, but it's really great for them to get involved in our community. It's extra human capacity. But really the ultimate goal is we hope that they fall in love with rural health, and they will practice either in Klamath Falls, that's the biggest hope, or they'll at least go to another rural community and practice there, as opposed to going back to a metropolitan area to practice. We also have a medical residency program within Sky Lakes that's part of OHSU, and I would say about 50% of each graduating class stays in Klamath for at least a couple of years. So that's been really helpful for us to meet the need of our community. We still could use oodles more, but regardless, that's been a really great a really great partnership. That building over on the right is just a sketch, but they're building right now the rural campus building right next to the hospital. And so we're hoping that we can not only see clients, but then have the students in a central location. So pretty exciting.
Can I ask a question about
Yeah.
transportation?
Absolutely.
On those visits, you said you had 1,042 rides you provided. Now, do you have vans or,
Yes.
so how many vans you have?
We have 3 vans, and they're all wheelchair accessible. And we, when we count our rides, so we also work with a transportation brokerage system called TransLink. And so people can call up TransLink and use their Medicaid transportation benefit just on their own. So those rides are only in our vans for that span of a year.
So who actually pays the insurance on the van, the maintenance on the van, and the drivers of the van? Who does that?
The CCO, so the Medicaid organization, they pay for that. And then, so like I said, if we have somebody who's on Medicare, because those are Medicaid dollars paying for it, we can't give them the ride. We're working with our hospital to figure out how would that funding work to be able to expand that benefit.
Because this is a really interesting concept that is paid by Medicaid, because Mary, do you know anybody in West Virginia that has vans that are overseen by Medicaid?
No.
Like we have, like it falls back on the individual client.
Mm-hmm.
Like the DHHR office will pay
Yeah.
for trips, like, but you have to find the person who will drive you to the doctor's
Sure.
visit and bring back. So
Right.
how was that, do you know how that was structured?
Well, and where it really started, so our CCOs are, so the federal government has the Medicaid dollars, it goes to the state. Then our state said, okay, each local CCO is going to do what they want for the most part with their dollars, but they have certain metrics that they have to meet. And obviously there's this baseline of benefits that have to be given. Transportation's one of them. Well, some of the metrics that have to be met are, for example, readmissions and inappropriate emergency department use and just thinking about cost savings, no-show rates for appointments and controlling A1Cs. That has to do with it because if you can't get your supplies, you're not going to the doctor, you're not going to control your A1Cs. So then the state had, I can't remember what the initiative was called, but they basically were giving each CCO transformation dollars, and we could do with it what we wanted. And so this transportation program was one of those programs that they provided the seed money for to pilot it and say, like, do we want this? Is it working? And it was working. And so then now how it's paid for is they have their members, right? 18,000 members. And every month they pay a per member per month amount to this hospital program to then run the program. So they have to make sure that they've got the vans, they've got the maintenance, they've got the people to run the vans, all that kind of stuff. And so that's how it's ongoing.
And how many years has it been in existence?
Since 2014. Yeah. And it's grown and changed a lot. And so the way that the rides work is we've got that brokerage, right? So it's TransLink. It's kind of this weird system. So Sky Lakes, who gets the Medicaid dollars, pays some of that per member per month money to TransLink to then broker the rides for the general Medicaid population. So if I say, I've got an appointment I can just call TransLink and do that myself. That is more self-sufficient than somebody needing to call, make an appointment with us, we come and pick them up. That's not sustainable, right? Because it's not a lifelong program. We're trying to give a hand up, not a hand out. So instead of buying more and more vans and trying to give everybody the transportation, we say, okay, we're going to give you rides for 6 months or whatever, and we're going to gradually ease you into using TransLink so that you are independent, you can make your own appointments, you can go everywhere that we could go before. And so that's where we're at today. Does that answer your question? Yeah.
And there is the development of a model in Huntington Washington now.
Oh, they do?
Yeah, the Marshall Transportation Institute, Marshall University Transportation Institute, in collaboration with a number of other people in the community. They got some federal dollars to develop this model, but they've just started implementing a transportation model, and it was precipitated because of the substance use problems there, but they've got people that need transportation in the middle of the night and didn't have any other vehicles, so this system now will pick these people up in the middle of the night, get them to services. It'll help people get to employment. I mean, there's a whole host of other activities going on around it.
Right,
So
right.
it's something to watch. It's just in the implementation phases now.
And something, by no means is it a perfect program. You know, there's kinks to be worked out. And we can dictate where TransLink will take folks. And so you mentioned, you know, grocery stores, and the community health workers in our vans will take people to the grocery store. But once they're just on TransLink services, that's not a covered location. And we've really waffled with it because other communities have done it and it was abused, unfortunately. People would say, oh, I need to go to the grocery store, and then they actually go and hit the liquor store right next door. So we haven't expanded to that yet. But like I was talking about KFOM, the online marketplace, that pickup location is nowhere near downtown. It's kind of off on its own place. So we feel very comfortable making that a destination so people can still get access to that. And then the produce connection sites, TransLink will take them there too. So, you know, there are a few gaps for sure, but we're trying to be good stewards of our dollars while also giving people access. So still in the works. Okay. So, oops, yeah. As you all know, working in the rural environment, there are pros and cons to everything. What we have found in our journey, and like I said, this is just a few things. We've seen challenges that it's a pretty conservative climate, and so things like tobacco prevention, that kind of stuff. It took us a while and some turnover in our elected officials to pass some stuff. Very low funding. We do a lot with a little, just like what Darren was saying. We have a lot of geographic spread and a lot of outlying communities, and we're still trying to do better about reaching them with our initiatives. And the other thing we found, and maybe it's the same with you, that 20% of the people are doing 80% of the work. And so trying to engage more people to step up and even just do a little is what we're trying to do. The pros of being a rural community is we're very close-knit. I can call up the CEO of the hospital and it's not weird. It's not, big some scary guy. And I see the mayor at the grocery store and, hey, Carol Westfall, whatever. So that's really great. It's easy to get involved because there's not that many programs to get involved with. And I would just say, we are resourceful. We are innovative because we have to be. And I hope you all see the same thing in your work. So what's next? We did a community health assessment in 2017, finished up in 2018. We are trying to finish up our community health improvement plan right now. We're just trying to tweak it, more so just to make it prettier. The content is all there. And I don't know if any of you have been involved in your CHA and CHIP process. Has anybody done that? Health assessment, health improvement planning? A few? Okay. We use the MAP model, which is mobilizing action through planning and partnership, which is a CDC model. And it's really great because it really goes step by step by step, and it's really comprehensive. So if you're starting a new process, I highly recommend using MAP. And within our health priorities, we went out to the community and we said, what do you guys care about? Here's our health assessment. Here's the indicators. What do you want us to work on? And so these were our top priorities: suicide prevention, infant mortality prevention, safe and affordable housing, food insecurity, oral health, and physical well-being. And what's nice about this year is we have social determinants of health and more economic things in there, and we've never had that before. So like the housing piece was new. It is new for us, and we're excited to see where that goes. But we have really great work groups in place already, and so it involves the Downtown Association, the Economic Development Association, the hospital, the CCO, public health, DHS, Action Services, all these people, because it's a problem, and it certainly affects our community health. you know, people come to us and they say, oh, you're doing all these wonderful things. How do you do it? How do you do it? And how can we do it too? And my key takeaways are opportunities will come to you if people who are doing cool things know that you're interested. Because everybody wants more people to get involved, right? I mean, if all of you said, I want to come help in Klamath, I'd say, great, let's go right now. They're only going to know that you are doing something or if that you're interested if you tell them. So you just got to raise your hand and ask. On the flip side is you have to tell people that you're doing cool things so that other people who might be interested can come to you and say, oh yeah, I can do that. And the other thing that we found to be very helpful, especially when working with our medical residents, I don't know if any of you know people who've gone through medical school, but they're worked to the bone, right? They don't have a lot of time, but they're really excited and they really want to help. So what's worked for us is to find little tiny tasks that they can do and feel really good about that doesn't take a lot of time. And it didn't have to just be the medical residents, it's anybody in your community. So we would say, you want to get involved but you don't have time? How about I write this letter for you and you sign it? Or how about I write this op-ed for you and I'll even submit it for you, can I put your name on it? Those are teeny little things that can make a big impact that take no time for that person. Obviously, there are others who maybe they're retired or maybe they're a stay-at-home mom and they've got a lot of time or they just love to volunteer. You can give them bigger tasks. They can help you write the grant. They can help find the grant. They can go to the city council meeting and give testimony for you. They can go and they can talk to the big CEOs or whatever on your behalf so that you have more engagement. But having that wide variety of options for what people can do is really, really helpful, at least in my experience, and hopefully you'll see the same. So we won the prize. We don't have a whole lot of time, nor do we have internet access, so I'm not going to show you our video, but you can either find it on the Healthy Klamath website, on the Robert Wood Johnson website, or Sharon is more than welcome to share these slides, and you can watch our beautiful videos, and it highlights some of the things that I've already talked about, highlights some of the things that I didn't talk about, but it has been a really amazing journey for us. And like Darren said, our journey is not over, it's just beginning. And we really like to meet with people like yourselves who are doing also very incredible work. And I'm sure we can find really cool things to talk about and share, which I would love to do. That's all I have. What other questions can I answer for you?